sorry guys, this enzyme exists in the lining of the bowel, and then when you eat something, that enzyme helps break down whatever carbohydrates need to be in the small intestine, and then helps you absorb more carbohydrates as the food goes down. So if you block that enzyme, then you won't absorb as many carbohydrates, and thus your blood sugar will go down. So it's supposed to be taken with the first bite of a meal, and if you skip the meal, you skip the dose. Side effects are nausea and diarrhea because you're changing the way your intestines are using glucose, which can make you feel sick to your stomach. Adverse effects, potential liver dysfunction, and iron deficiency anemia. And because this medication is blocking the breakdown of carbohydrates, you will not be able to treat hypoglycemia by giving food. So our hypoglycemic plan that we talked about prior to the lunch break was if we were awake and able to follow directions and swallow them, we would just take in some juice or something. But if I gave this person something to eat or drink that had sugar in it, they won't be able to absorb it, and so it won't help them. So they actually have to have glucose tabs with them, and that's the way that they will be able to increase their blood sugar. And then the last medication that is part of the quiz is a gliptin. It's called sitagliptin. And instead of manipulating insulin, this medication actually increases, well, actually it does increase the release of insulin, decreases glucagon, and increases another hormone called incretin that decreases your appetite and slows down your GI tract. So it's manipulating all those hormones. You can take it daily with or without food. Side effects are headaches and nasal congestion. Adverse effects, and this can be deadly, is pancreatitis. So we mentioned one of the seizure medications led to pancreatitis. We didn't really get into as much what kind of symptoms that would be. So first of all, does anyone remember which seizure medication causes pancreatitis? Yes, it is valproic acid. So if I asked that question and you had no idea or didn't remember that we talked about that, then that is a clue that you probably didn't study enough for the exam. But yes, it is valproic acid. What are the symptoms of pancreatitis? Right, upper abdominal pain. So the pancreas lives in the upper abdomen behind the stomach. So people can have pain like in that epigastric area radiating to their back. It's very, very painful. People know when they have pancreatitis. They can have nausea, vomiting, decreased appetite. They do not feel good. The what blood test would you um, check if the provider thought somebody had inflammation of their pancreas? So Lillian says LFTs, potentially, right. So potentially very bad pancreatitis will actually affect the gallbladder and the liver as well. But you will see an elevation in the enzymes that the pancreas creates. When amylase and lipase, especially lipase, are very sensitive, that is a very sensitive indicator to the degree of inflammation of the pancreas. Just in case that comes up as a test question. And then the other issue is Stevens-Johnson syndrome. So that is what those oral hypoglycemics, so starting with slide 15, which introduces that topic, and then those 6 medications all the way up to slide 23, is what the next quiz will be about. So be sure to study for that. I will let you know if our site gets fixed so we can move everything back to where it's supposed to be, or if we have to remain on the lab thing. And I will look back at the percentages and at least give you to the 10th, round it to the 10th place, just to keep, everything as fair as possible for you guys. A couple people. Oh, thank you, Angela. I have you down. Then the only person um, oh no. Oh goodness. Yes, it's so fun to have school with children around. And then the only person who hasn't signed in then is Angelique. So I don't know if you were here, Angelique, and didn't, while we were just talking now, didn't sign in. Now would be a good time. But I'm glad you are back. Angela, I hope your child is okay. All right, so now the next part of diabetes care is injectables, which are medications obviously that we can give for diabetes that are actually subcutaneous injections instead of pills. Insulin, of course, is the most common one that we use. You cannot give insulin orally, and this is an important point. Only regular insulin can be given IV. All of the insulins can be given subcutaneously. Usual side effects of insulin therapy, which could range from side to adverse effects depending on how severe it is. Of course, we could overcorrect. We could give the person too much insulin and they end up with a low blood sugar. Insulin changes how potassium moves in and out of the cell. So it's potential that we could bring their potassium level down. And then this lipohypertrophy means that they get like a scarring, bumpiness under the skin, and that issue occurs if you don't rotate the sites. So it's not just that you should rotate, different arms, the abdomen, but you should rotate within that area. So if I decide I'm going to be giving my insulin injections in my lower abdomen in the right lower quadrant, that right lower quadrant is a big square, and I should, even while I use that right lower quadrant, pick slightly different areas within that boundary so that I'm always trying. I don't want to put excessive trauma just on one piece of or type of tissue, otherwise I'll start to get scarring and nodularity to that skin. So side effects to adverse effects depending on how severe of insulin is hypoglycemia, hypokalemia, and lipohypertrophy. We have talked about medications already that can affect glucose. The furosemide and thiazide can cause hyperglycemia. Beta blockers make it harder to stay away from the navel. That's very true. You want to keep a boundary around there because the fat is the least usually there, and then you're very close to where there's a defect in the fascia or the tough covering of the abdomen, because you have your fat, your muscle, and fascia, which is sort of like the hard covering of the muscle, and underneath there's some as well, and you don't want to breach that. You end up in the abdomen, and that's really not where you want to deposit the insulin. Okay, so insulin obviously is going to be a medication on our exam. You can keep it open and outside of the refrigerator as long as you use that within the next month. So I could store all my insulin in the refrigerator, and then the one that I take out that I'm going to use for the next month is I can leave it out just out of heat and light. It's best not to give it cold, so you should warm it up in your hands if you're just pulling it out of the refrigerator. Giving it cold does increase the risk of that lipohypertrophy, where they get those nodules on their skin. This is a very, very important slide, although I think I've said that about everything, but you want to memorize these times, onset, peak, and duration, because it can apply to multiple types of questions. It kind of helps determine when you want to give the insulin, and it lets you know when the patient is at their greatest risk of hypoglycemia, which is what you want to know. And this is based on the two common insulin regimens that are available. One insulin regimen uses regular and NPH insulin. Regular is a short-acting insulin, and NPH is a longer-acting insulin. And you can use them both to cover meals. And the other option is to use a very long-acting insulin like glargine, and then an extremely short-acting insulin like Humalog. And there's benefits to either of those, and it does drive the schedule of the patient and when you're going to give them something to eat, which is always questions on the exam. So if I am taking regular insulin, here's my day. I have to take the regular insulin 30 minutes before I'm going to eat. So it starts to work in 30 minutes. So here's my meal. So this is me at home, because the hospital, has all kinds of different rules. So here's me at home. I like to take and have my breakfast at 8 o'clock, say. So around 7:30 is when I should administer my regular insulin. So I need to eat an adequate breakfast, because now I gave myself this insulin. It's going to peak in 2 hours, 7:30 to 8:30 to 9:30. So I gave it here. It's going to start to work here. It's going to peak at 9:30. So hopefully as all of my breakfast has made it through my stomach and into the small intestine and being absorbed into my bloodstream, I will have my peak amount of regular insulin. And then it's going to wear off. Oops, where are you? It's going to wear off in 5 hours. So I gave it 7:30, 8:30, 9:30, 8:30, 9:30, 10:30, 11:30, 12:30. So by 12:30, that regular insulin that I had is gone. So I've covered my breakfast by giving regular insulin before breakfast. So say I have a couple of options now that it's lunchtime. I could give myself another dose of regular insulin and then have the same thing. So at 12 o'clock, I could take regular insulin, and then 2 o'clock, I would peak again. And then 5 hours from that, so right around 1700, when I'm about to have supper, I would be down again. So then I would have to take another dose of regular insulin in order to cover my supper. So that's one way I could do it, that I would use regular insulin, 3 times a day. The other way I could do it to decrease injections is to give a mixture of regular and NPH, because if I do that, then I can decrease the amount of injections I have to give myself. So here I am again. I'm giving my insulin at 7:30, and this time I give regular and NPH. And so I eat my breakfast at 8. I have my onset at 8. It was at 9:30 that I had my peak, covering my breakfast. And then once I got to 12:30, it was gone. So because I took the NPH, then I can skip doing a regular insulin dose at 12:30, because the NPH will cover my lunch. So if I take NPH, the onset is about an hour, and it's going to start to peak around lunchtime. So that's 4 hours in. It's usually 4 to 6 hours is when it's going to peak. So it's going to start peaking by the time it's time for lunch. So here's my NPH. It's going to be peaking through lunch, and then it's going to come down It can peak in 4s and it can last up to 18 hours. So I could have pretty good coverage all the way as I get into supper. So now maybe I just give myself another dose of regular insulin for supper time just to help me with the evening. And I've cut down on my injections. So there's usually a question, what meal am I affecting when I give a certain insulin dose? So when I give insulin in the morning, I'm trying to treat my breakfast. If I give NPH in the morning, I'm actually treating my lunch. It's not going to affect the breakfast at all. Does that make sense? Because that's usually a question. It might be stated either way, like regular insulin at in the morning is for which meal? And we can say that it's for breakfast. NPH we can say is for lunch. There are people that sometimes when they get to this point take regular and NPH together, which means they need to take a snack at bedtime because the regular insulin is going to take care of their supper. Oops. And then the NPH is going to take them through towards nighttime. Whoops. So they have to take a snack for sure if I'm going to give them regular and NPH at supper time. So then maybe I just give these two combination meds twice a day. And this is a cheap way to give insulin. It used to be cheaper because, drug companies can decide to price gouge consumers, which they do because this type of insulin was created in the 1970s, and the man that created it didn't even want to patent it because he wanted it to be available for patients at a low cost who had diabetes. But now whoever owns regular and NPH, they have increased the price of this insulin regimen, which used to be extremely cheap. So this is a nice alternative for people that don't have good insurance coverage usually and don't want to use a lot of injections. And the questions will always be, if I give regular insulin prior to, at 1600 or 1700, then obviously I'm treating my supper. If I give NPH at that time, then I'm treating my bedtime snack. So keep that in mind. The other type of insulin regimen is what's called Lantus and Lispro, or Glargine and Humalog. And this is supposed to mimic the way the body usually handles insulin, which is to have a constant low level of insulin being, pumping out from the pancreas into the bloodstream. And then with meals, there'll be a big bolus of insulin because you ate. And this is exactly how this regimen is supposed to be. So you would take Humalog insulin just with your meals right before you eat, knowing that it'll peak and only last during that meal. And this long-acting insulin, Glargine insulin, is just going to be covering you throughout the day. So this actually allows for a more open schedule. Like say your schedule changes every day. A lot of you guys talked about that when you did the community pharmacy project, that your schedule changed all the time, so it was hard doing something that had to be predictable. This is a really good option. So at about 10 p.m. at 2200, you would give yourself the Lantus, which would then start to work, and that will keep going throughout the day. It does not peak. It stays at a constant rate for 24 hours, and that's what we want. And then I would give my next dose always in the evening before bed. And then say maybe I only ate 2 meals that day, not 3. It would be when I had my meal that I would take the ultra short acting insulin. I would take the Lispro, because it would start working right away, peak, and come down, so that it just covered what I ate. And then if I didn't eat again till later, I could give it then. So it's much more open to what my schedule is. Whereas here I have to keep my schedule pretty predictable, because if I don't eat, I gave these beforehand, now I have to deal with it. Otherwise I could drop my blood sugar. The other thing to remember with these types of insulin plans is how you draw them up and give them. So if you're going to give regular and NPH together, you inject air first and then you draw up the solution. So you inject air into the NPH and then the regular insulin, and then you draw up the regular and then the NPH. And the reason you do it like that is because you're trying not to mix them. And the way I remember it is I always want to pull out the medication regular first, NPH second as RN to see if that helps. That's what we want to be. When you give Lantus and Lispro, you can't mix Lantus or glargine insulin with any other insulin. It has to be given by itself. And then you give the Lispro when you're going to eat. So if you ate towards the time that you're going to go to bed, you would have to give yourself 2 separate injections. So that is insulin. Does anyone have a question about insulin? Okay, so now there's 2 other injectable medications. Nope. Awesome. There are 2 other injectable medications that you can use, sometimes as a way to not have to use insulin, to try to, decrease that possibility in a person that's a type 2 diabetic. And sometimes it's for specific problems that the patient has, namely if the patient has really high blood sugars after they eat. Some people have that, what it's called is postprandial highs, which essentially means after they eat a meal, their blood sugar goes very, very high. So you can take these other types of medications as a way to decrease those postprandial highs. And the first one is an amylin mimetic, or meaning it acts like the hormone amylin, which is another hormone that the pancreas makes at the and it decreases gastric emptying, so the person feels full, and decreases the amount of glucagon, so that means we're not breaking down our storage of glucose. So we're going to hopefully eat less, and then we're not going to activate storage, so hopefully the sugar goes down. So we give this sub-Q injection 30 minutes before a meal, and especially if the meal is very high in sugar, because a meal very high in sugar will have a very high postprandial blood sugar, and this way we can prevent that. So it takes about 20 to 30 minutes to work, and then it peaks at 3 hours. And so this is the time where we would have to worry about hypoglycemia. So they do have to eat enough to make this worth using, so they don't get hypoglycemia. Sometimes people will be on an insulin regimen and still have really high postprandial blood sugars, and so they might decide to take this medication with their insulin, and then they really increase their risk for hypoglycemia. So they'll have to be very careful in terms of the dosing of both of those medicines. And the last injectable medication is an Incretin mimic, which is a medication that acts like the hormone Incretin, and it's Exenatide, which was marketed as Byetta, which isn't used as much because it did have some issues after it came to market, namely pancreatitis. So this medication acts like Incretin by decreasing gastric emptying, so that means it slows down the stomach so you are full faster, so you might eat less, increases insulin, and decreases glucagon. So this is again a medication that you could take 60 minutes before morning and evening meals. And people also noticed when they took this, probably because it was decreasing gastric emptying, that they did lose weight. So that was the added benefit of this medicine. However, it can cause hypoglycemia, so you have to be careful about that. And it can lead to kidney disease, which is always an issue for diabetics, so you have to watch that. So what is the blood tests I would do if I wanted to check the patient's kidney function? Yep, the BUNs and creatinine are the ones that specifically measure kidney function. What kind of symptoms will the patient have? Edema, because they're going to retain fluid. If the kidneys aren't working, then we're not filtering fluid into urine. And then that fluid has to go someplace. So their weight goes up, they get swelling, short of breath because that edema can be in their lungs. Their blood pressure can go up because there's extra fluid in their vessels. That's all true. Good. And then we just talked about pancreatitis when we were talking about the gliptins. So again, that would be that really bad pain, nausea, decreased appetite, and then it's the amylase and lipase that we would check to see if that was the problem. So that's all of our medications for diabetes. So, but the quiz will be about the oral hypoglycemics. So we'll just start with antidiuretic hormone before we take our break. So the next group of medications that are related to hormones have to do with something called the hypothalamus pituitary axis. So it's not one, when we're talking about diabetes, we're talking about the pancreas making hormones, and sometimes the pancreas isn't working correctly, so we don't get the hormones that we need. This is a different type of endocrine function. The hypothalamus is in the brain, and it is responding to information from our environment about what our needs are, and it has a special communication with the pituitary gland, which is also in the brain. They have a special shared blood supply so they can communicate with each other. And the pituitary has what's called an anterior portion and a posterior portion. The posterior portion creates two types of hormones. One is antidiuretic hormone and one is oxytocin. The anterior pituitary creates thyroid releasing hormone, corticotropin releasing hormone, gonadotropin releasing hormone, and growth hormone releasing hormone. So these are kind of precursors. They're going to go to a different organ. This one goes to the kidney, and we're going to talk about that. Oxytocin we're going to talk about when we talk about reproduction, because that's, although it does have other functions, one of its big functions is contraction of the uterus and labor and delivery. And we're not going to talk about gonadotropin releasing hormone, but we will talk about medications that help with the growth hormone, medications that help with thyroid function, and medications that help the adrenal gland. That's the last things that we have to talk about. So ADH, growth hormone, thyroid hormone, and the adrenal gland hormones. So this is obviously a much better picture of the hypothalamus, where we're receiving messages from the higher brain, and that communicates with the anterior and posterior pituitary, and they will send their hormones out into the general circulation to different glands in the body in order to tell that gland to do something or to produce its own hormone. So it can get kind of complicated depending on how many steps there are till you get to the hormone that you want, that you need the production to be in the right range. And the first hormone we're going to talk about is called antidiuretic hormone, and it means exactly what it is. It means we're stopping diuresis. We want the kidney to save urine. So if everything is working normally, the kidney itself is constant. There's constant monitoring in the nephron. The osmolarity is the fancy word, but essentially it means concentration of the fluid in the nephron, which is the urine. And if we start to notice that the fluid running through the nephron is starting to get too concentrated, that would make us increase our thirst because we need more fluid, and our body would release antidiuretic hormone so that we save water, that we can hopefully decrease the concentration. So we're trying to keep the concentration at a particular level. We can look at it the same way we looked at blood glucose. This time we're trying to keep the concentration or the osmolarity of the blood at a certain level. It's usually, we like it to be about 200 milliosmoles, 280 milliosmoles. But that's what we want our blood to be concentrated at, because we don't want fluid to shift in and out of cells or fluid to shift in and out of blood vessels. So if the concentration starts to get too high, that will tell the brain to release antidiuretic hormone, and then our kidneys will keep water instead of losing it in the urine to bring the concentration down. Once the concentration gets to a certain point where we're in the normal range, then we will stop telling the brain to release antidiuretic hormone because we don't need it anymore. So if the bloodstream gets too concentrated, we'll tell the kidneys to hold on to water. If the bloodstream starts to get less concentrated, then we'll say, it's okay, you can urinate now. And that's how it's supposed to work. For some people, what will happen is they will lose the ability to concentrate their urine. There's a particular type of disease called diabetes insipidus. It's not very common. It could happen after a brain injury of some kind, or it could be a genetic dysfunction, but for some reason the body stops releasing antidiuretic hormone, even though it usually would. And the person starts to urinate a large amount of very dilute urine. So someone with diabetes insipidus, if they're getting rid of all that fluid, will start to develop an increase in osmolarity or concentration in their bloodstream. And we don't want that, because what happens when when things get too concentrated inside the vessel is it'll draw fluid in, so the patient is more likely to become very, very dehydrated. And it can also start to shrink cells, and we don't want the cells, especially in our brain, to shrink. So we don't want to have diabetes insipidus. In diabetes insipidus, we're going to be way up high here, but because we're not releasing ADH, we can never bring it back down. We're just stuck up here. So that means we have to give somebody medication that will act like antidiuretic hormone so that we can stop this problem. That is the treatment for diabetes insipidus, is to give them a medication called desmopressin, or DDAVP, that is like ADH, just, synthetic, made in the lab. Some of the older formulations were made with peanut oil, but obviously lots of people are allergic to peanuts, so they did change that. The IV form of DDAVP is a vesicant, so you have to be careful that the IV is in the right spot. It can be given IM, subcutaneously. The patient can take it at home intranasally, so you have to be sure to review proper installation of intranasal medications, because you don't want the medication, you don't want the patient to like sniff in while you're giving the medicine, have the medication go down the back of the person's throat, or they're not going to get it. What you want is to take advantage of the side of the nose that has all that mucus so that it can be absorbed into the bloodstream of the mucus membrane. So you have to point that nozzle to the side laterally towards the ear. So be sure you remember that. Point that nasal medication toward the earlobe. So the medication is aimed to the side of the nose. Otherwise they won't get it. Or you can take it by mouth. So you give the medication because you want the patient to save water. The problem is you might do it too well and they end up saving too much water. And then they can have signs of confusion and fluid overload with hypertension. And that is often the case when you're giving medications for an endocrine problem. The patient has diabetes insipidus, and so their blood concentration is too high, and they are getting profoundly dehydrated and having cell shrinkage. So I can give them desmopressin to reverse that, and that means they could be normal concentration, and so they're not dehydrated, they don't have too much fluid, they don't have any symptoms of cell shrinkage. That would be the ideal situation. But if I accidentally, or the way it was dosed, give them too much desmopressin, then it's going to be the other way around. I'm going to be way less concentrated, so very, very dilute. Sometimes this is called water intoxication, like you have too much fluid. So the patient's sodium will be really low, and they're actually at risk for the cells to get really big, to swell, and they could get headaches and seizures. So we obviously don't want that. We want to keep it in this range. So anyone who's taking this medication will have to have their blood pressure monitored, because that tells us something about their fluid status. Their I&O, so be sure it's equal. Want their sodium checked. If their sodium level is too high, then they're not on enough medicine. If it's too low, they're on too much. And it's the same with osmolarity. If their osmolarity is too high, that's the problem. They're not on enough medicine. If their osmolarity is too low, then they're taking too much, and the dose will have to be adjusted. So it's a fine balance, keeping them in the right range. So we'll stop here as we move on to growth hormone, and we'll come back at 2 o'clock. The next hormone we're going to talk about is growth hormone. So growth hormone is released by the pituitary gland after the hypothalamus tells it to, and it will then decrease adipose tissue and will travel to the liver and release a hormone called insulin-like growth factor that will increase the length of bones and increase muscle mass. So very important during particular times of life, especially growth and development in childhood and when you get your growth spurt in adolescence. It is also part of how we utilize glucose when we are exercising and things like that as well. So growth hormone function is muscle and bone growth. If somebody is born deficient in growth hormone, they could get a condition called dwarfism, or they will be smaller than normal. If they have an excess amount of growth hormone, then they can develop a condition called giantism. We are talking about treatment for someone who has a deficiency in growth hormone, and that would be then would be treated with somatropin. And usually the people that are treated for this are children who are not making height and growth curve. They're way below the baseline, and they end up seeing an endocrinologist and have a deficiency in growth hormone. And so they're given extra growth hormone to try to meet developmental markers. So somatropin is expensive. It's a subcutaneous injection that's given 3 to 4 times a week for several years. You give it until the growth plates fuse on the bones. So each bone, the long bones, especially in the arms and the legs, have what's called a growth plate. There's an area right here on the bone that allows bone to grow further. And at a certain age, that growth plate seals. And so even if you give somebody extra growth hormone, their bones can't get any longer. So you're trying to find the children that would benefit from this to increase their long bone growth before the growth plates fuse. And so that's what you're looking here. You're evaluating the growth plates of the bones. So people take this for several years. At some point, some people develop resistance to the medication because they start to create antibodies to it. They will need regular follow-up, monthly height and weights to see how they're doing, and annual x-rays to see if that growth plate has fused. People who are severely obese or have difficulty breathing can have an increased risk of breathing issues with taking growth hormone, and so they shouldn't. People who have closed or fused growth plates should also not take growth hormone. And if they are critically ill, in intensive care or have some other illness, then they should not take growth hormone either. It's not a time where we should promote growth of bones and muscles. We should be working towards healing. So it's not commonly given medication, and you certainly would be working in a specialty area. The next thing we're going to talk about is disorders of the thyroid gland. So your thyroid is responsible also especially for metabolism. It sensitizes the body to the sympathetic nervous system, so it helps that work better. It helps the body utilize the fuel that's created by glucose, the ATP, and increases the amount of ATP in times of growth. So it is our metabolism hub in our neck. It is another hypothalamus pituitary axis endocrine function. So the hypothalamus produces thyroid releasing hormone, which stimulates the pituitary gland to release thyroid stimulating hormone. And thyroid stimulating hormone tells the thyroid gland to make thyroid hormone. Which is T3 or T4, and what that targets the heart, liver, bones, and the brain and helps with metabolism. If the body has created enough, if this thyroid releasing hormone causes the release of thyroid stimulating hormone, which causes the release of thyroid hormone, if we have enough thyroid hormone, that acts as a negative feedback to say, okay, you don't need to stimulate the thyroid gland anymore. We have enough thyroid. And it should be that we have this normal thyroid level that we want. If there's too much, too high, then we have hyperthyroidism. And if it's too low, Then we have hypothyroidism, and these are both conditions that we can give medication for. If somebody's thyroid gland is not functioning well, if they're hypothyroid, they will have a decreased metabolic rate, and so they have complaints that make sense for people whose metabolic system is running slower. They gain weight, they're cold, they have constipation, they're depressed, their skin and nails get really dry. So everything's slowed down. If the thyroid gets super, super low, then they can have low blood pressure, low heart rate, and they can start to be in a coma and things like that. But this is when people usually notice that there's a problem. If the thyroid level is too high, then the patient will have the opposite type of complaints. They'll lose weight, they'll be hot and sweaty, they'll have diarrhea, they'll have insomnia and anxiety. Everything's revved up. And at the very extreme end, they could end up with very high blood pressure and very high heart rate, which is called a thyroid storm. So these are the extremes. Most people will present with these other types of symptoms. So just like when we talked about antidiuretic hormone, we had a problem, we used the medication. One of the issues or one of the adverse effects is that we're giving too much. So keep that in mind when we're talking about it. Have our thyroid function, that means our metabolic rate is correct. If we have hypothyroidism, we would give someone medication to replace their thyroid. But if we give them too much, they're going to end up with hyperthyroidism. If the patient has hyperthyroidism and we give them medication to bind the thyroid hormone, if we give them too much, they're going to end up hypothyroid. So we just talked about those symptoms. If the person is hypothyroid, then we have to replace the thyroid hormone by giving them synthetic thyroid hormone. You're not going to really see the full benefit until they've been taking it for several weeks, and then people will get blood tests until they end up in the right range, and then usually they get the blood tests yearly. And the side effects can range from side effects to adverse effects, and they're related to overtreatment. So instead of patient feeling normal again from being hypothyroid, they'll have symptoms of hyperthyroidism. So that's what we would look for. If the person has hyperthyroidism, then we can give them a different type of medication called PTU, which interferes with the synthesis of thyroid hormones. So they will have a less thyroid hormone. And this is given several times a day, 1 tablet every 8 hours. This medication has a couple more things to worry about. So yes, just like the opposite, if the patient has hyperthyroidism and we give them medication and it's working too well, they could develop symptoms of hypothyroidism. However, and if the patient becomes very hypothyroid, they might actually develop a low white blood cell count, which puts them at risk of infection. They also have to worry about other adverse effects, such as aplastic anemia. So this is a low white blood cell count. This is a low red blood cell count. And hepatotoxicity, which we've talked about now a couple times, liver disorder. And this can't be taken in pregnancy. So levothyroxine, or the medication for thyroid replacement, is a little bit easier to remember. It doesn't have as many things. PTU has the side effects of overtreatment, but it also has some extra issues with white blood cells, red blood cells, and the liver. So that's the thyroid. Does anyone have any questions about ADH, growth hormone, or thyroid hormone before we move on to the adrenal gland? Okay, so the adrenal gland is a special organ that sits on top of each kidney, and it has several functions. The adrenal gland itself has two areas, the cortex and the medulla, it's called. It's the middle area. This medulla area is one of the things that produces norepinephrine and epinephrine in response to sympathetic stimulation. The cortex produces three different hormones: androgens, which are, oh, thanks, Rita. Androgens, which is everyone can get testosterone in their body. Even women produce androgens in their adrenal gland. And we'll talk more about androgens when we talk about the reproductive medications. And so that's why gender is a continuum. You know, it's not just determined by the genetic code. It's how you display your genetic code has to do with hormonal influences too. So there is hormonal influences as well. And everyone can make testosterone and everyone can make estrogen. And depending on how much or how little you create of those hormones can change how you display your sex chromosomes. Anyway, so we'll worry about androgens later. The other thing that cortex produces is glucocorticoids, which is cortisol, which we've talked about a couple times now, and mineralocorticoids, which we've also talked about, which is aldosterone. Aldosterone is part of our fluid management. It's the end point of the renin-angiotensin-aldosterone system. If we create aldosterone, then we are saving water. Cortisol is our stress hormone, and our replacement, we've talked about replacing cortisol or treating inflammation with prednisone, which is similar to cortisol. Now we're talking about it in a different way. So this is another hypothalamus, pituitary, adrenal gland, this time hormone axis. So the hypothalamus produces corticotropin releasing hormone, which tells the pituitary gland to produce adrenocorticotropic hormone, which is what tells, this is the pituitary, what tells the adrenal gland to make any of those hormones that it makes: androgens, cortisol, aldosterone. So the stress hormone, we know cortisol helps increase sensitivity to the central nervous system. It suppresses inflammation because it's not time to worry about that. It will break down bone and muscle to increase blood sugar. So we are trying to assist the sympathetic nervous system response. If someone has adrenal insufficiency, which is the most common reason to have a deficient cortisol, it's because there's been an autoimmune damage to the adrenal gland itself. So even though the hypothalamus and the pituitary gland are telling the adrenal gland to make cortisol, if the adrenal gland doesn't work, it can't happen. So if someone has an adrenal gland that doesn't work, that's called adrenal insufficiency, or Addison's disease. And if someone has Addison's disease, then they will need to be given medication that is like cortisol. And in this case, it's called hydrocortisone. We've talked about medications that are like cortisol, meaning prednisone, because we were giving higher doses because we were trying to really suppress inflammation or organ rejection. So that's how we talked about it before. We talked about it as a treatment for rheumatoid arthritis, or those autoimmune inflammatory conditions of the joints. We talked about it as part of the treatment regimen for organ rejection. Now we're talking about a lower dose preparation called hydrocortisone that is meant to be cortisol replacement for people that don't make cortisol anymore. And so we're trying to help decrease the symptoms of less cortisol, and we could end up giving them too much. So just like every other hormone problem we've talked about, the patient is supposed to have a certain amount of cortisol. And if that's working, then that'll help augment the stress response when we need to, and it helps our sleep-wake cycle, and it has other actions in the body as well. If we have Addison's disease, then for some reason the body isn't making enough cortisol, so the cortisol is too low. When that happens, the patient will be very tired and especially have a very low blood pressure. And those are the biggest complaints of people with Addison's disease. And so our treatment would be a preparation of cortisols because we would want to get them back in the normal range. However, if we overtreat, we'll end up with the opposite. Too much cortisol gives the person a condition called Cushing's disease. And that means they're going to have elevated blood pressure, but all kinds of other problems. That's the people with the moon face and the buffalo hump, and their blood sugars are too high, and their weight is up, and there's kidney dysfunction, and so those other things that we've talked about. So we want to keep them in this range. So we just want to replace the cortisol without over-treating them. So excessive use and prolonged use could lead to Cushing's-like syndrome. If a person has Addison's disease in times of stress or illness, they're going to need to increase their dose of hydrocortisone, and they should never stop the hydrocortisone suddenly, or they will feel worse. These are the long-term potential issues that people can have when taking the dose of hydrocortisone for Addison's disease. So if we stop it abruptly, the patient will then go into potential renal failure and very low blood pressure. So usually a person that's developed Addison's disease will not be able to come off this medication. That'll be lifelong. And the last medication we have to talk about is oftentimes people with Addison's disease have an overall decrease in the production of glucocorticoids and mineralocorticoids. So that means they're also going to have a problem with aldosterone production. So we talked about a medication that blocks aldosterone. Does anyone remember what the medication was that blocked aldosterone? Way back in the cardiovascular unit? Hello? Is there anybody out there? Yes, spironolactone. I interpreted that. That we gave because the person had elevated blood pressure, and we gave spironolactone so that we blocked the effect of aldosterone so they would have less fluid, which would bring their blood pressure down. In Addison's disease, they're not producing aldosterone, and we don't want that. That could mean their blood pressure is too low. You did good. So we can give them fludrocortisone. So it's a cortisone, and it's for fluid. That's sometimes how I remember it. Fludrocortisone is taken usually with hydrocortisone because the patient will have decreased cortisol and aldosterone production together. Taken every day or 3 times per week. Again, the adverse effect is that we got too much. So we have to remember, here we are, our aldosterone level, which means we would have a good blood pressure, normal blood pressure, and a normal sodium and potassium. If the patient had low blood pressure, that's the normal, if their aldosterone level was too low, then they cannot save fluid, so their blood pressure would go down. as well as their sodium, because they're not saving fluid, and their potassium would go up if your aldosterone level got too low. If we decide, okay, they have Addison's disease, I'm going to give them fludrocortisone, I'm hoping that they're going to end up here, but sometimes we overtreat. And if we gave them too much fludrocortisone, it's possible that their blood pressure could go up, and their sodium will go up, and their potassium will go down. So it depends. We're always trying to keep a balance. So the hard part about this test is that you have to remember, what is this hormone for? How would I know if it was working? If I did not have enough, what would that look like? If I had too much, what would that look like? You have to kind of keep remembering what that means. And because whatever you're treating, you want things to be normal, but if you overtreat, then it's going to go in the opposite direction. So you have to keep thinking about that, which can sometimes make that a little bit difficult. So does anyone have any questions? So I think I did get an email or two. If you need to meet with me, I will send an email back to you so we can set up an appointment. If you need to go over the exam, please send an email to me so we can set up an appointment. Next class is the quiz. You have to do the endocrinology ATI with a score of 85% or better. Then you have to do the quiz in the beginning of class, which will be about those oral hypoglycemics, those 6 medications. And then we will do material about respiratory medications, and we'll take the practice ATI, just so you know what we're doing next class. So have a good week. I will talk to you next class.